Now I'll request Dr. Mizanur Rahman Khan, Dr. Sanjib Chowdhury, Dr. Tanjima Parvin, Dr. Fahdia Afroz, and Dr. Kalim Uddin. Please come over to the dais. And I'll also request Professor Chaudhry Meshkat Ahmed sir and Dr. Pradeep Kumar Konga sir to come up to the desk. Our first presenter is Dr. Farhana Ahmed. She will be talking about challenges that makes you better, not bitter. Please, Dr. Farhana Ahmed.
It's beautiful and full of challenge. And every day in our life, we need to tackle a lot of challenge. But the challenge is worthy when something newer things come out, and that brings the smile and hope to the patient. Ladies and gentlemen, respected panelists and audience, very good evening. I'm going to tell the story of a 75 years old pleasant gentleman who presented with breathlessness on exertion, chest pain on exertion, mild exertion, and history of AVR 12 years back. Patient was hypertensive, diabetic, having CKD, creatinine level 2.4, and patient was also suffering from COPD. And his echocardiography revealed there is a high gradient across the prosthetic bulb. The gradient is 109 millimeter of mercury, that is the peak gradient, and mean gradient is more than 80 millimeter of mercury. And the patient have mild AR, having grade 3 diastolic dysfunction. Ejection fraction is 45%. So we are dealing with a case of 75 years old gentleman who has been suffering from biprosthetic aortic valve restenosis, who have lot of comorbidities like hypertension, DM, CKD, and COPD. And his STS score is 6.63, which he belongs to the moderate risk group. And I'd like to mention here that the patient previous surgical experience was not that soothing, as he has got some post-operative complication and take longer time from recovery. So he had some denial from surgical operation this time. So what should be the good option for this patient? Should he go for a redo surgery? But the risk of redo operation is higher than the first operation. The higher mortality and morbidity compared with the first time AVR involve more complex procedure, and frequently at advanced age, like our patient, have relevant comorbidities that may increase the operative risk. And therefore, not only the patient, but also the caring physician may be reluctant to operate for giving the option for reoperation until symptoms become very severe. For this patient, TAVR might be a very attractive alternative option, TAVR valve-in-valve, which is minimally invasive fashion without the need for cardiopulmonary bypass. And the TAVR provides a perfect, the previous valve provides a perfect circular platform to allow even expansion of the transcatheter heart valve, and it also provides a perfect anchoring tools for the TAVR valve. And it is obviously a shorter duration, procedural time, and can be performed under conscious sedation with a general anesthesia. And the patient recovery time is very early. Patient can be discharged from the hospital within 3 days. And if it is done by the experienced operator, the TAVR procedure might be a very soothing one for this patient, like the diagram showing in the slide. So the animation is showing that is the TAVR in valve procedure. And the world, in the last two decades, we are seeing that the worlds are moving towards the TAVR procedure, and lot of patients going through the biprosthetic valve in their early stage, who later on presented with a biprosthetic valve restenosis, the valve-in-valve might be a good option for this patient. And partner valve-in-valve registry also support this evidence. And the VIV TAVR is also associated with lower rate of 30-day mortality and major bleeding, but high rate of severe patient prosthetic mismatch. And the meta-analysis of the 6th study also shown, despite higher predictive surgical risk of bulb-in-bulb patient, there is no difference in mortality, but less PPI and dialysis compared to redo-saver. But the operator must have a detailed understanding of the anatomy and fluoroscopic appearance of the surgical bulb. TAVR design, as not all the TAVR bulb are the same, the correct sizing of the bulb, the ideal implantation position for the chosen bulb within the existing saver bulb. And the specific challenge is coronary obstruction, especially in the case of a stainless bulb, TAVR migration and embolization, and higher residual gradient. So a very meticulous CT analysis of the aortic bulb is needed before TAVR bulb-in-bulb operation for the analysis of the structure of the aorta, ascending aorta, aortic bulb, as well as the proper sizing of the TAVR bulb. In our case, this is the slide of our case. Here, the rim of the, we have to detect the true internal diameter of the surgical bulb for proper measurement of our TAVR bulb. The inner diameter was 20.8. As the patient have pericardial bulb and the leaflet is mounted in the inner, so we have to add 2 millimeter more. That is, our predictive bulb size is 22.8, but we took 1 millimeter size over. That is, we predict the bulb size would be 23 plus from the CT analysis. And then from the CT, we also can delineate the implantation view, that is the LAO 19 and cranial 14. And we also can assess whether there are any chance of coronary obstruction by VTC distance. In our case, the RCC VTC distance is 7, but for the left coronary, it is 3.8. Any distance less than 4 have chance to coronary obstruction. And we have adequate femoral artery diameter, aortic diameter, except few mild calcification. And coronary angiogram showing borderline lesion in mid-LAD and LCX. First of all, in our procedure, we did it in a highly equipped lab, and with our highly expert team, and our vascular and surgical colleagues are on call if there is any complications. First of all, the right side femoral axis was introduced, and the left-sided femoral artery puncture was done from right-sided guidance. Sorry. And then the balloon tip TPM placed from the left side and check stability with 180 pulses. Then the insertion of 7 French sheet to the right side, insertion of extractive wire, insertion of 9 French, and then subsequently 11 French sheet, and the insertion of finally the Python sheet, which is about 15 millimeter, 15 French, and heparin 100 unit per kg was used. As from our CT analysis, we have anticipation there is a possible occlusion of the left coronary artery during the procedure. So what we did, we again checked the left coronary artery, and it shown the left main artery and LAD was within normal limit except few plaque. Then what we did, for the protection of left main during placement of and dilatation of the TAVR bulb, we put EBO guide catheter non-selectively and encouraged guide extensor catheter into the left main deeply and put PTCA wire, keep PTCA wire into the LCX. And if any, and put another stent 3 millimeter into 30 millimeter length stent, just keep into the LCX to for the if any coronary obstruction happen at the time of bulb deployment, so that we can protect the left main at that time instantly to pull back the stent and we can dilate it easily. So we just put the stent to keep into the LCX for just to prevent the prevent the left main occlusion at the time of device deployment. Then we cross the aortic valve with the AL catheter with straight tip pterymo wire. Then the step tip pterymo wire was exchanged with a pre-sized sapphire, extra backup sapphire wire. Over this wire, we perform all of our procedure. And we took, this is the TAVR bulb, 23 millimeter diameter. And the size is determined, I showed already from the CT analysis. After introduction of the crimped TAVR bulb, over navigator through the Python sheath, at the thoracic outer level, flexing with the help of proximal shaft with rotatory handle in navigator delivery system. And we place it across the previous saver bulb. Once the position of the bulb on the second dense band at the level of the annular plane, here the annular plane is the previous surgical bulb is act as the annular plane here. And once they're satisfied with the position, start rapid pacing, wait for pressure fall, and then start deployment of TAVR bulb. Once the bulb properly inflated, then deflate, stop pacing, and check hemodynamics. And this is the final result after TAVR bulb deployment. And then we again check for coronary. The coronary was unaffected by the bulb. So we pull back all the system with the stent. And finally, we took a gradient across the bulb, which is less than 10 millimeter and is acceptable gradient. And the post-procedural echo was good. And the gradient is only 6 to 7 millimeter across the aortic bulb with no or minimal aortic regurgitation. And this is the first bulb-in-bulb case in Bangladesh. And we acknowledge our team headed by Associate Professor Pradeep Kumar Karmakar sir to introduce such a challenging and challenging procedure which gave benefit to the patient who are often under-addressed. So my take-home message is, bulb-in-bulb therapy is a rapidly growing alternative to a redo operation when treating degenerative saver bulb. In short, 4 steps should keep in mind. First step is identification of the degenerative saver bulb, including its model, size, even fluoroscopic appearance. The second step is to determine the type and size of TAVR bulb. Third step is to assess the risk of coronary obstruction. Finally, the route of approach must be carefully planned. Once these aspects are addressed, the procedure can be performed efficiently with a low risk of complication. So the future is to bulb-in-bulb in TAVR, and this is, I don't say this is the end of redo saver. Redo saver is limited for limited option, where there is a chance of coronary obstruction is higher or there is a very narrow aortic route. Otherwise, most of the case, we can treat this sort of patient with bulb-in-bulb TAVR. And the future is TAVR, bulb-in TAVR, or TAVR surgery, then bulb-in-bulb. Thank you so much for your patience hearing.
Thank you, Dr. Farhana, for your nice, excellent, and very informative presentation. Our next speaker, Colonel Dr. Mohammad Abdul Malik.
Respected Chairman, Panelist, and my learned audience. Good afternoon, everyone. My topic is the angiogram that rarely I have seen. So let's see my patient. He is Mr. AMK, 58 years old. He is hypertensive. He presented in the early morning with a typical angina for 2 hours. Presenting blood pressure is 110/70 and pulse is 95 beats per minute. In EKG, there are ST change in the multiple leads. This is the ECG, indicating that possibly patient has got multifaceted disease or late main disease. He has mild apical hypokinesia in the echo, with ejection fraction is 50%, and troponin is positive. So, this is a case of non-STMI, high risk. He was optimized with the medicine initially in the emergency department. After initial treatment, his ECG improved. But he has ongoing angina with gradually low blood pressure. Considering the unstable hemodynamics, very high risk non-STMI, he was planned for early angiography. Patient was brought to the cath lab within 2 hours of the presentation. So, this is the left-sided angiography. Unfortunately, occluded left main, but RCA is normal. Naturally, scenario is worsening gradually. Patient goes to the cardiogenic shock. He was given optimal multiple inotropes. And patient is a father of a doctor of the same hospital. In this scenario, what to do? Rescue PCI or CABG? Clinical scenario is like this. Non-STMI with unstable hemodynamics, left main total occlusion, normal RCA. He is a father of a doctor of the same hospital, and lot of attendants are outside waiting for the good result. There is no mechanical circulatory support in the hospital at that time. Synthesis score is 40. I considered 40 because to calculate the synthesis score, we have to give the information regarding the LAD and RCA. So if I consider the occluded left main, the synthesis score goes to 40. There is strong surgical backup. So far, there is no clear-cut guideline. So, cardiologists thought that patient will be benefited by surgical intervention. So, referred the patient to surgeon. And for intervening time, patient was sent to the critical care center for immediate stabilization. In the critical care center, patient developed VT, cardiac arrest, patient was resuscitated, kept on inotropes, and cardiac surgeon declined to operate the patient. At that time, patient is in cardiogenic shock, ejection fraction further reduced to 35%. So, only option is either PCI or medical treatment. Heart teams including the cardiac surgeon, anesthesiologist, all available seniors sit together, discussed with the NOK regarding the possible worst outcome, and considered the risk and benefit of the procedure, and then plan for the rescue PCI. Basically, this is the scenario for a cardiologist who is operator like that. He is in the firing squad and facing the immediate disaster. So, once patient is the cardiogenic shock, rapidly patient was wired, and after balloon dilation, patient again developed cardiac arrest in the cath lab table. He was reverted to the sinus rhythm, and after resuscitation, this is the coronary, left side coronary. Distal left main is critical, and there is diffuse disease in the LAD and LCX. What we can see here, critical left main with diffuse disease in LAD LCX, and what we can do, we decided to put the stent to the distal left main. But patient is continuous on VT, CPR is going on, and simultaneously, if maximum effort was taken to to put a stent to the left main. At one stage, stent was implanted in the distal left main, and patient again developed VT, resuscitated again, resuscitation going on, and this is the final result, fairly final result after stenting. But still patient is on CPR. After CPR for about 30 minutes, unfortunately patient died. What lesson learned in this patient? There are some facts here. We all know that incidence of acute MI with cardiogenic shock is almost 7 to 10%. In hospital mortality is almost 80%. Around 50 or 60% of patients had triple vessel disease, and with 20% patient involving the left main. There are a lot of guidelines to support the acute MI, non-STMI, and cardiogenic shock. But what says about this type of patient? Shock patient, there are both options, revascularization and medical treatment, but revascularization favors in patients who present with the shock in the early stage. If you see the guideline, emergency coronary angiography is recommended in patient with ACS with cardiogenic shock. We did this part correctly. If you see here, in patient who require revascularization for significant left main disease with high risk, high complexity coronary disease, it is recommended to choose CABG over PCI to improve survival. But here, significant left main disease, left main is not occluded. So guideline is not clear here. Regarding the use of mechanical circulatory support in the cath lab during the high risk patient, there is a role of IBP and Impella. And both this GUSTO and shock trial, they describe in favor of mechanical circulatory support, although 6-month outcome was almost similar in both cases, both groups. And there is a recommendation that for non-STSCS related mechanical complications, the use of IBP should be considered. It is class 2A indication. We did not have this facility at the time. If we compare the ESC and JSC guideline, SSC guideline, both considered emergency angiography and emergency revascularization for shock patient. But there is no clear-cut indication regarding the occluded left main. So this is one of the recommendations. It is recommended to base the revascularization strategy in multivessel disease, PCI or CABG, on patient clinical status, comorbidities, as well as the disease severity. One thing they have mentioned, the decision on immediate PCI of the culprit lesion stenosis does not require any heart team consultation. So whatever you want to do it immediately. So regarding the infarct vessel revascularization, these are the guidelines. In patient with STMI and ischemic symptom less than 12 hours, PCI should be performed to improve survival. In patient with STMI and cardiogenic shock or hemodynamic instability, PCI or CABG is indicated to improve survival irrespective of time delay from MI onset. And this SEC guideline also favors in favor of revascularization. Take home message, total occlusion of the left main is rare but extremely life-threatening. Optimum treatment or guideline is not clear. Prompt and aggressive treatment may save the life. Acute MI with cardiogenic shock with left main total occlusion, there is no clear-cut guideline. Thank you very much.
Thank you, Colonel Malek, for your presenting some such courageous case and reminding us about that sometimes we are failed to rescue a patient in spite of our all efforts. Now, may I request Dr. Swadesh Kumar Chakraborty to present his case on known way difficult destination.
Respected chairperson and learned audience, very good afternoon. I am Dr. Swadesh Kumar Chakraborty, working at Shohid Sheikh Abu Nasser Specialized Hospital, Khulna. My topic, known way but difficult destination. My first case, Mr. X, a 43 years gentleman, presented with severe central chest pain for 5 hours. He was a smoker, normotensive, non-diabetic. Pulse was 104 beats per minute and blood pressure 110 by 70 millimeter mercury. ECG showed acute anterior STMI. Echocardiography revealed anterior wall hypokinesia with moderate to severe LV systolic dysfunction. This is ECG, which shows extensive anterior MI. So, it's a extensive anterior STMI with 5 years chest pain. We decided to take the patient in cath lab, and this was the angiogram. It showed LED is occluded from the ostium, and RCA was disease free. We decided to fix the lesion of the LED. We felt difficulty as there was no stump in the LED, but after a couple of minutes we find our way, and the procedure was done without much more complication, and this was the result. You see, it was acceptable result. So, though initially we did not have any way, but we find our destination. My second case, a 44 years gentleman, known case of inferior MI, presented with chest pain on exertion. He was normotensive and non-diabetic. Pulse rate was 70 beats per minute, blood pressure was 110 over 70 millimeter mercury. Echo revealed inferior wall hypokinesia with ejection fraction around 50%. CAG showed single vessel disease. RCA was 99% stenosis at mid part. This was RCA. You see, we decided to revascularize the patient. We took run through floppy wire. Initially faced difficulty to cross the lesion, then changed our wire to whisper wire and took balloon support across the lesion. But we felt difficulty to predilate the lesion as we failed to cross 1.25 balloon through the lesion. We took another body wire, but it still failed. We did not have any advanced tool to overcome the problem, so we postponed the case and referred to higher center. So, in this case, we know our way, but we failed to reach the destination. My third case, a 69 years lady, non-diabetic, hypertensive, presented with chest pain with respiratory distress. She had a past history of non-ST elevation MI with recurrent episodes of hospitalization. She had on standard medical management. On examination, pulse was 88 beats per minute, blood pressure 110 over 80 millimeter mercury, and bilateral basal crackles. ECG shows non-specific STT changes, and echocardiography revealed inferior wall hypokinesia with mild to moderate LV systolic dysfunction. This was angiogram. We show left main is short but normal. LCX is diseased from the after origin of OM1, and OM is very tight lesion, and the LED is non-critical lesion. You see, but RCA again at 99% stenosis at the mid part. We decided to fix the RCA lesion and the OM. We took run through floppy wire, but again failed to cross the lesion. Our guide was not providing enough support. We took another body wire and changed the wire to whisper, and after balloon support, we crossed the lesion. We took 1.125 balloon and predilate, then gradually increase the balloon size 2 and 2.5, keeping the second wire in the lumen to crack the calcium, and the bed is prepared. Finally put a stent post dilation, and the OM was also fixed. So, Mr. Chairman, in conclusion, about 20 to 25% patients have severely calcified coronary artery stenosis, advanced age, hypertension, diabetes, and dyslipidemias are associations. Severe calcified lesions may cause stent under expansion, malapposition with high rate of failure and restenosis. High pressure, non-compliant balloon dilation, use of cutting or scoring balloon may improve the outcome. Sometimes rotational atherectomy, laser coronary atherectomy, or intravascular coronary lithotripsy are required. Thank you. Thank you for patience hearing.
Thank you, Dr. Sadequl Chakraborty. Now I am request Dr. Atikur Rahman to present his case, no flow in stable angina patient.
I are accepted chairpersons, honorable panelist, and learned audience. Assalamu alaikum, very good evening. I am Dr. Atikur Rahman, Assistant Professor, Silat Usmani Medical College, and my topic is no flow in stable angina patient. This is the history of the patient, Mr. X, 45 years old, stable angina, in spite of 3 anti-anginal drug, hypertensive, smoker, and non-diabetic. ECGT inversion in inferior leads, ETT positive, and echo no wall motion abnormality, and EF around 60%. And we do CAG of the patient, left main normal, LAD 80% stenosis in mid part, LCX normal, RCN 90 to 95 stenosis in mid part, and 70% stenosis in proximal part. And we decided to do CAG plus minus revascularization. We'll give loading dose of antiplatelet and hardware wires, guide wire JR7, BMW wire, and Ifura SC, and resolute integrity, and NC balloon. These are the angiogram of the patient, LCX normal, and LAD is mid part 70 to 80% stenosis, and the RCA is and mid part 90 to 95% stenosis, and proximal part is 70 to 80% stenosis. We decided to fix RCA first and then LAD. We gave a BMW wire, we successfully crossed the wire and pre-dilate the lesion. And we put a stent 2.75 into 18 in mid part. And after putting the stent, we inside the stent, there is a haziness inside the stent, and put another stent 3.24 in proximal part. After putting the stent, there is slow flow, and few minutes later, patient develop no reflow. And what might be the cause of this no reflow? We thought it might be thrombus inside the stent, or dissection occurred during wire passing or pre-dilatation, followed by thrombus formation after stent deployment, and PCI on a calcified lesion. Then we use drug adenosine, JP inhibitor, GTN, and patient develop hypertension. We use ionotropes, multiple ionotropes, and these are the final result. Though it is not optimum, but reasonable final result. These are the take-home message. No reflow is common in SCS, in culprit lesion. Sometimes no reflow can occur in stable patient during PCI. Adequate antiplatelet before the procedure and heparin during procedure should be used. Proper heparinization of hardwares should be done, especially in used hardwares. Periodical backflow of guides should be done. These are the terrific condition of Silet, flooding natural disaster in Silet Usmani Medical College. So pray for Silet. And I also lost my original presentation during flood, and flood affected my hospital, and we lost our all hardwares. Thank you very much.
Thank you, Dr. Atikur Rahman for your brilliant case. Now may I request Dr. Abdul Qayyum Khan to present his case.
Welcome you all in my presentation. My patient, 48 years old migrant worker from Saudi Arabia, underwent PCI to RCA in 2014. Now he presented with non-STMI while visiting Bangladesh. His risk factor hypertension, echo shows regional wall muscle abnormality, ejection fraction 33%. Kidney clearance was good. The ECG, as his angiography shows, trifurcated left main severe stenosis, Medina 111, involving the LAD, LCX, and ramas. LAD was 90 to 95 stenosis in proximal segment, starting from its origin, giving some collateral to RCA. Ramas was 80 to 90% stenosis in proximal segment, starting from its origin, LCX non-dominant and totally occluded. RCA was dominant vessel, multiple lesion through entire length of RCA, including ISR. So you advise him CABG. But as patient was migrant worker, patient and his family refused CABG. So after discussion with the clinic heart team, we planned for stage PCI. First we tackle RCA with deploying two DS. This is the final result. Then after 1 week, we plan for PCI to left into LAD and ramas. We take EBO7 French for left. This is the angiography. Then both vessels were wired and pre-dilated with 220 balloon, NC balloon. So we took left into LAD run, and it shows calcification in left main and proximal LAD, and stenosis in severe stenosis in his distal part. You can appreciate nice OCT picture. As I'm short in time, so this is a left into ramas OCT run. It also shows calcification in distal left main and proximal part of ramas. So pre-dilate with a scoring balloon, 2 into 10 in ramas and 2.5 millimeter and 12 millimeter in LAD. And 2.75 into 12 millimeter scoring balloon for left main to LAD. Then again we OCT run from left main to LAD, and we found the bed was nicely prepared with some dissection. So we plan for two-stent strategy, decay crash. First, we take 2.75 80mm DS for MS and 3 into 10 millimeter balloon for LAD. We inflated as stents in 12 atmosphere and slightly pulled back and re-inflated into at 18 atmosphere. Then whole assembly was taken out and stent was crushed by 2.710 NC balloon. Sorry, the crash was fast. I missed the slide. I crushed the balloon 3 into 10 millimeter NC balloon. Then rewired the LCX, and our first case done 3 into 10 millimeter NC balloon in LAD and 2.75 10 millimeter NC balloon in ramas. And we take 3 into 38 millimeter DS from left main to LAD, inflated in 12 atmosphere. Re-inflated and shows good distal runoff. So we pot 3 into 3.5 millimeter 12 millimeter NC balloon and in left main, and our final case 3 into 12 millimeter NC balloon for LAD and 2.75 millimeter NC balloon for ramas. So we push dilate the whole LAD and pot with 4 into 8 millimeter NC balloon for left main. So we post-procedure OCT done from left main to LAD, and OCT shows nice demonstration of stent. Stent was nicely opposed, no under expansion, but distal portion landed in a disease portion, but no dissection. So we plan for putting another stent in distal portion of LAD. We take 2.75 into 14 millimeter DS in mid LAD, inflate 14 atmosphere. Then again post-procedure OCT done, and it shows stent was nicely opposed in whole length, no under expansion, no malopposition. This is a final result with good distal runoff. So, in severe trifurcated distal left main and calcification involving LAD and proximal ramus is very much challenging. While bed preparation with NC balloon and scoring balloon is key issue in this case, two-strand strategy like DK cash show good long-term outcome. Proper balloon, proper kissing, pot in report essential for long-term outcome. And intercorneal imaging optimize the result immediate and long-term. So, we believe in teamwork. Our mentor, Professor Fazil Malik, always says, our strength is team. So, thank you from NHF team.
Thank you very much, Dr. Qayyum, for presenting such difficult case with brilliant outcome. Now, may I request Dr. Afzar Hossain Bhuiya to present his case on novel innovation made complex PCI simple.
Honorable Chairperson, Panelist, and audience, good afternoon. My topic is novel innovation made complex PCI simple. I have nothing to disclose. KH, 65 years old, female, hypertensive, diabetic, dyslipidemic patient, ESRD on mechanical hemodialysis 3 per week, complaining mainly of effort angina class 2-3 for last few months. She had a history of fall prior to admission. ECG showed normal and echo there is no RWMA and EF is 60%. CT scan brain showed mild subfalcine hemorrhage with resolved in repeated CT. Carotid duplex showed mild diffuse atherosclerotic changes in right carotid arteries. And CAG showed critical calcified TVD. Left main is calcified and normal. LED type 4 vessel, diffuse calcified vessel has got 80 to 90% stenosis at its proximal to mid segment. Diagonal branches are small and ostial disease. And LCX is good size vessel, calcified, has got 60 to 70% stenosis at its mid segment. OM2 is reasonable size vessel with mild disease. And RCA dominant vessel, calcified, has got 80 to 85% stenosis at proximal to mid segments, followed by mild plaque at distal segment. And what will be the treatment option? After heart team discussion, decision was made to go for PCI with IVL as CABG refused by surgical team. Patient party agreed with us and we went for PCI. LCA was engaged with the guiding catheter EBU 3.5 6 French. The Sion blue wire was crossed, the lesion of LAD, and dilated with 2 into 15 balloon at 10 to 14 ATM. After predilation, I was done, and I was shows severe calcification, concentric calcification. And the calcified segment was dilated with IVL support using 2.5 into 12 millimeter balloon. IVS is continuing. There. IVL continues from distal to proximal segment. And after IVL, IVA study was done and calcified area was well prepared for stenting. Due to time constraint, I am not showing the IVAS fully. And then mid to proximal LED was stented with 2.5 into 38 millimeter DES at 12 to 14 ATM. and overlapping the previous stent and covering the proximal lesion with a 2.75 into 35 millimeter, 32 millimeter DS at 12 to 16 ATM. And post dilatation was done with 3 into 10 millimeter balloon at 12 into 18 ATM. And the final angiogram showed LAD was well dilated with timid 3 distal flow. This is the post stenting IVAS showing both stents were well apposed. After the PCI to LAD, patient suddenly developed acute left ventricular failure. For this, PCI to RCA postponed. Patient sent to CCU for stabilization. Immediately dialysis started, and after few days patient became stable, and then we proceeded further for PCI to RCA. And then RCA was engaged with the guiding catheter JR 3.56 French. The Sion blue wire was crossed, the lesion of RCA, and pre-dilated with 2 into 15 balloon at 10 to 14 ATM. After pre-dilatation, I was done and found the concentric heavily calcified vessel. Then the calcified segment were well dilated with IVL balloon 2.5 into 12 millimeter. IVL continuing. And after IVL, IVA study showed calcified area was well cracked. I am not showing the full IVAS. Lesion was stented with 3 into 34 millimeter stent at 12 to 14 ATM. And post dilatation was done with 3.5 into 10 millimeter balloon at 14 to 22 ATM. And after post dilatation, IVA study was done and showed stent was well apposed. Final angiogram showed RCA was well dilated and the previous LED stent is patent with timid 3 distal flow. This is the IVL system. And in conclusion, considering the age, comorbidities and extent of calcification, it was a very complex and high bleeding risk patient to deal with. But with proper planning and use of appropriate technologies, we have overcome all the hurdles. And in take home message, calcified lesion is always a challenge for the interventionist. New innovative technologies are becoming available to make the interventions easier. All armaments should be ready in the cavalry, and patience is the key to success. Patients are the main center of focus. Thank you. Thank you for your patience hearing.
Thank you, Dr. Thank you, Dr. Afzal Hossain Bhuiya, for present a nice and excellent case. Now I am request Dr. Mohammad Shamim Chowdhury to present your case.
Honorable Chairperson, respected panel of expert, learned audience, good afternoon. I am going to present my case, that is double trouble hurdle to reach the destination. Mrs. X, 35 years old lady with a history of CRTP implantation, 6 months back, came to our emergency department with the complaints of shortness of breath, NYHA class 2 or 3, tiredness and palpitation. CRTP was implanted due to non-ischemic dilated cardiomyopathy with the ejection fraction of 28%. On query, she gave history of LV lead dislodgement on third period of her CRTP implantation. She gave no history of vomiting or extraneous activity or any illness between this period. This was her admission ECG that showing the QRS complexes are wide with only the RV pacing and LV pacing is missing. So in the view of dislodgement of her history, So we integrated the device, and an X-ray test, it showed that LV lead is displaced and it is looped in the right atrium from the coronary sinus. Her routine investigation was done, and it was quite okay. With the echo was directed LV with severe global LV systolic dysfunction with LV ejection fraction 28%. This was her first ECG during before the CRTP implantation. That is showing the white QRS complexes with LVBB morphology. And that was our last ECG during the discharge with narrow QRS complex with biventricular pacing. So fluoroscopy was done, and that shows that the LV lead is dislodged into the right atrium and looped into the right atrium. So we planned for the reimplantation of the repositioning of the LV lead. So LV lead was removed, and we tried to put an CS sheath to cannulate the coronary sinus. We used a floppy wire to cannulate the coronary sinus, but we failed after several attempts. Then we took the help of a CS catheter to cannulate the coronary sinus, and with the help of a CS catheter, we cannulated the coronary sinus, and coronary sinogram was done. And through the coronary sinus sheath, we passed a floppy wire into the middle cardiac vein, and in the support of the floppy wire, we implanted the LV lead into the middle cardiac vein. As there is a discrepancy between the lead diameter and the venous diameter, we decided to fix the lead into the venous system by means of an stent. So we inserted another floppy wire, that is the run-through wire, beside the LV lead, and implanted a drug-eluting stent (4 into 12 millimeter), deployed at 8 atmospheric pressure, and followed by high inflation was done at 16 atmospheric pressure, and LV lead was fixed within the venous system. And after a gentle traction, it was confirmed that the lead is being fixed within the CS. And this is the final picture showing that LV lead is being fixed and the stent in situ in the proximal part of the LV lead. And this is the ECG just after repositioning of the CRTP, that is showing the narrow QRS complex with biventricular pacing. And this is the ECG after first month of follow-up. So in spite of improvement in lead design and delivery system, high incidence of lead dislocation is observed. It is between 2 to 12%. The use of coronary stent technique has been proposed as an alternative method for stabilization of the LV lead in patients who experience repeated dislocation. First case report of a coronary stent to stabilize the lead in the coronary sinus was published in 2006. Several studies concluded that the lead stabilization by stenting based on coronary vein anatomy can effectively reduce the dislodgement rate from 10% to 1%. This is a case report recently published in the European Research Journal that is done in the New Delhi, India, where they used a drug-eluting stent to stabilize the lead. So in conclusion, stent implantation to stabilize the left ventricular lead position seems to be a useful and safe procedure in the treatment of patients with complicated coronary sinus anatomy or lead instability due to the size discrepancy. And I'm thankful to my mentor, Professor Mir Nasaruddin sir, for his case, and my cath lab team of National Heart Foundation Hospital. Thank you all.
Now we are almost at the end of this session. For this, I am requesting Dr. Fahdia Afroz to say a few words about the cases.
Thank you, Tahmina, and also Shyamal. It was a wonderful CD presentation session. All the presenters presented so nicely because all are experienced and doing very well in their own sector. One thing I have observed here some of us also mentioned where we failed. This is the main thing. When we can address our problem, I think success depends on there. Congratulations to all of you.
Thank you, madam. Now may I request ask our Professor, Dr. Pradip Kumar Karmakar sir, to say a few words about the presentations.
Thank you, the young cardiologist. Their working is brilliant. First case was Tevar. I was the part of that the Meshka sir would tell something. I wanted the second case, Abdul Malik. It was a nice case, and actually you are in the firing squad. Especially when the patient is doctors, fathers and mother, we are in the trouble jeopardy. What is happened, it is delayed, first thing. And the revascularization should be maybe improved if you go through the two stent, mid to distal and mid to the left main including. It may be a good option. When you bring the patient in the cath lab, only the left main opening is not the job. You should at least open the LED. Then it may save the life. Then the Shodesh, he is doing good in Khulna. In first case, as well we do for the MPI in post-MI cases for the vascularization. And second case probably the wire in the false lumen. For this reason you have failed to cross the lesion. And third case is nice. Nomar is also doing good in Silet. And that the hazy part in the RCA, there are the three causes for a hazy part. Initially due to platelet glue. So you should give that adenosine and the integrilin. If it is clear up, is okay. If not clear up, it is distal, then think that distal is dissection. The age dissection do not happen in the middle. And proximal age dissection is insignificant. And then second thing is tissue prolapse. And third thing is stand star fracture. What do? We go for the balloon, expand the dilate it. If the haziness increase, it is the start fracture and go for the second stand. And if it is if it is tissue prolapse, then it will be the flow will be restored. Abdul Qayyum is a good presentation. Always the trifurcation in the left main should be treated as bifurcation. And Afzal calcified coronary arteries with IVL is a nice presentation, and the Samim nicely presented his displaced lead management. Thank you. I am handovering my mic to my chairperson.
Sir. Thank you, sir. May I request our respectable professor, Professor Chowdhury Meshkat Ahmed sir, to conclude the session and say the concluding remarks.
Thank you very much. It has been a fabulous afternoon of intervention by the young cardiologists. They have crossed all the hurdles. They have made all the complex things simple. We grew in a time when we used to spend half an hour to see whether there is any air bubble in the manifold. From there now we have a person sitting just beside me who have done the TAVR in Bangladesh. Congratulations to him. It is a difficult job, but we are very proud of all of you. Thank you very much for being here.
Thank you, sir. Now the praise giving part of the session. May I request Professor Pradip Kumar Karmakar sir to hand over the crest to Dr. Farhan Ahmed. Thank you, sir. I am requesting Professor Chowdhury Meshkat Ahmed sir to hand over the crest to Colonel Abdul Malik. I am requesting Dr. Fahdia Afroz, Madam, to hand over the crest to Dr. Swadesh Kumar Chakraborty. I am requesting Dr. Sanjib Chowdhury to hand over case to Dr. Atikur Rahman. May I request Professor Chowdhury Meshkat Ahmed sir to hand over the case to Dr. Abdul Qayyum Khan. I am requesting Dr. M.D. Kalim Uddin to hand over the case to Dr. Afzar Hossain Bhuiya. May I request Dr. Fahdia Afroz to hand over the case to Dr. M.D. Shamim Chowdhury. Thank you, Honorable Chairpersons, Moderators, and Panelists of this session.